Okay.
Ladies and gentlemen, good evening. Sorry for a little delay, which is because of some technical problems, but now we are on the in good way, I would say. So, welcome to the new initiative from the Research Committee of the European Society of Endocrine Surgeons, which is termed ClubEndoSurg. The concept is that every 3 months, the Research Committee selects one very interesting paper that was published in the last few months, and we have an invitation sent to the main author of such a paper to present it during 20 minutes, and then we have 3 invited discussants who will discuss some interesting points of such a paper. So today we have Ana Koman, Dr. Ana Koman from Karolinska Institute from Sweden. Thank you very much for accepting this invitation, and we are very fortunate to have you here. So we are ready to listen to main thesis and outcomes of your paper, which is entitled Neuropsychiatric Comorbidity in Primary Hyperparathyroidism Before and After Parathyroidectomy, a Population-Based Study. After your presentation, we have 3 invited discussants, Professor Jose Mackay, Cristina Martinez Santos, and Frederic Tripones, and they will ask you some questions with regard to your paper. So, Anna, the audience is yours.
Thank you very much for this invitation. It's an honor for me to get the chance to present my research. And I apologize for the technical problems. I don't know what happened, but anyway, so we start from here. And Marcin, did you have the possibility to share, or Sir, to share the presentation?
Yes, Anna, can you hear me?
Yes.
Okay, I will start with your with sharing your slides. I hope it will run okay. Do you have the presentation now?
Yes, I do. Very good. So I can just tell you next then when it's time for that.
Yeah.
Yes, very good. Okay. So next then, I say. Yes, primary hyperparathyroidism is the 3rd most common endocrine disease, as we all know, with a prevalence around 1%, and in postmenopausal women, more than 3 to 5%. And next, please. Neuropsychiatric symptoms are common in primary hyperparathyroidism, and medications like depression, anxiety, and difficulties in concentration and focusing, also muscle pain. And the biochemical approach to this are to logic and unknown. This constitutes a diagnostic dilemma. What is what in this? These symptoms are difficult to distinguish from diagnosis or aging. They are difficult to quantify. Since the symptoms are subjective, there are often overlapping symptoms and medications that are approved after PDX.
Okay, Anna, can you hear me? Do you hear me? Anna, do you hear me?
Yes.
Okay, possibly there is a problem with your connection. Is it possible that anybody at home turns off their wireless connection, and you even can turn off your video as well, so that may have possibly a better connection?
Yes.
We have feedback that people cannot hear you because of the weak connection. Do you get me?
Does it work better now?
Yes, I think you turned on something else. We hear you twice now.
Okay, I think I better log in again.
No, now it's better. Please do not log in. Now it's better.
Okay, now I hear it double, unfortunately.
Can you try to move on, Anna? I think we lost connection. Anna, can you try to speak?
And now?
Yes, can you try to speak now?
Yes. Do you hear me now?
Yes, better.
Yeah, it seems like it's some kind of major problem here I've had, but now I think the connection is better. And now I also can see that I can share the screen, but maybe we should just keep on the way we do.
Okay.
Yes, so something went wrong in the first connection. So I continue. The neuropsychiatric symptoms constitutes a diagnostic dilemma, and to predict the effect of parathyroidectomy is difficult. And when it comes to classical symptoms, the indications are fairly easy. And you can take the next slide, please. But in patients with only neuropsychiatric symptoms, it becomes much more difficult, and decision for treatment often becomes arbitrary. Next, please. So the question is, who will benefit from PTX and who will not, and when shall we operate and when shall we not? So I would like to introduce you very briefly to our previous study, which gave rise to the research question for this paper. And it's a clinical trial that we performed aiming to explore the use of short-term calcimimetic treatment as a diagnostic tool to predict the effects on neuropsychiatric symptoms and the quality of life after PTX. And we can take the next. I will do this very fast. And the target for this study was the calcium sensing receptor that all of you know is abundant in parathyroid cells in the distal tubuli of the kidneys and in the cardiovascular system, and also widespread throughout the central nervous system. So what we did was that we planned by means of decreasing the calcium level through using a calcimimetic compound. Our hypothesis was that the effect might mimic the effects that you could achieve after parathyroidectomy. Next, please. So we included 110 patients scheduled for PTX. They were given calcimimetric treatment for 4 weeks prior to surgery, and we measured quality of life, cognitive functioning, and psychological functioning, muscle strength at 4 occasions, as you can see in the figure. So first at baseline before giving medication, and then during medication, and 6 weeks post-operatively and 6 months post-operatively. Next, please. And what we found was that the calcium levels, they decreased nicely during the treatment and continued to decrease after surgery. So we can take it next. And what we also found was that while the calcium levels decreased, the scores on the quality of life test and most of the domains increased as the calcium level decreased. And we found that we got similar effects during medication as we had post-operatively. So the positive predictive values were good, while the negative predictive values and the way of ruling out any improvement were worse. Next, please. And we performed a sub-analysis of patients 50 years or older, screened with mild cognitive deficiency, defined by MoCA score less than 26, since we thought this was clinically relevant. This is a group of patients that not mandatory are selected for surgery. So next, please. And what we found here, I will explain this very briefly. On the y-axis, we have the scores on this MoCA test, and 26 is considered normal. And we have the age scale on the x-axis. And the white dots represents the patients preoperatively at baseline, their scores, and the red dots are the same patients, but postoperatively, 6 months postoperatively. And as you can see, I can take next, please. Yeah, and among 35 patients, as much as 19 patients reached normal scores, and this was irrespective of age. Next, please. So, some but not all patients had a significant potential to improve after surgery, irrespective of age and cognitive status. So this gave rise to this question: how about the impact of PHPT and PTX in the population? So this gave rise to this article, Neuropsychiatric Comorbidity in Primary Hyperparathyroidism. And it's a population study. The aim with this study was to investigate the impact of the disease on a neuropsychiatric morbidity and the effects that we could achieve, that could be achieved after curative treatment, and this in a population perspective. And we intended to figure out if there were any differences in the among the patients compared to the population, if the calcium levels did play a role in this, and if there were any age differences, and if it changed postoperatively. So how to study this in a population setting? Next, please. We considered studying the prevalences of diagnosed codes corresponding to neuropsychiatric symptoms. Next, please. And it's one way, but the problem is that diagnosed codes tends to accumulate. They are sometimes uncertain in their classification, and in our case, they were missing for primary care. So we instead considered to analyze prescribed drugs, which is in a way convenient in our country. We have a very well-validated drug register with 100% coverage. We have well-classified drugs, and this enables longitudinal both retrospective and prospective analysis. So in the end, we decided to include both in this study, both to get an overview, but also to validate the congruence between diagnosis and treatment. So 8,626 patients who underwent parathyroidectomy during the years 2008 till 2020. They were recruited from our quality register, and a matched background population was selected from the total population register, and it was 86,260 controls included in this. To this, we linked national patient registers for diagnosed codes, operation codes, and the prescribed and administered drug, and also from the cause of death register. And from the total population register, we could get data on education, employment, and immigration. Next, please. This is a flow chart that is also published in the paper. 347 patients were excluded to enable 3 years coverage of the drugs. Next, please. And the study was made in 2 parts. The first part is a case control study that aimed to map the presence of neuropsychiatric comorbidity as reflected by psychotropic medication. And the second part is a cohort study to analyze the effects on drug utilization after PTX. So the surgically treated patients, what did they look like? And we can see that they are quite common, quite typical for our modern primary hyperparathyroidism patients. The median age was 62 years. There was 77% females, and the hypercalcemia was generally mild with a median of ionized calcium 1.44 millimole per liter. And psychiatric symptoms and fatigue was recorded in more than a third of these patients. Not mandatory for indication, but they were recorded. And the retrospective part is a case control study where PTX was set as an index date, and the analysis was a backlook, which means before parathyroidectomy. Next, please. And the calculations or the analysis statistically were made with a conditional logistic regression in the first part, and they were performed by a professional statistician who is also a co-writer for this paper, to analyze the odds ratios of drug use. Next, please. And what we found was, next, please. I'm sorry about this. That psychiatric disorders, when we looked at the diagnosed codes, psychiatric disorders were more than twice as common in the PHPT patients compared to the background population the first year before parathyroidectomy. Next, please. And if we looked, when we looked back 5 years, it was less. So the closer you get to the operation, the higher was the odds ratio for disease. And further on, we looked at the age groups divided in quartiles, and what we found there was a bit surprisingly that psychiatric or neuropsychiatric symptoms or medicals was dominating in the younger age groups. So when it comes up to patients older than 65, the difference wasn't so great. It was still significant, but not as great as it was for the younger patients. And this is a radar chart of psychotropic drug use, odds ratios in a look back. And the black dotted line represents the background population, and this is set as a 1. And the red line, the outer line, represents the year before the operation, and the blue line represents 3 years back look. Yes, next please. Then we also performed analysis of the relation to the calcium levels. And there we also found something quite surprising. And the next, please. And we found that the overuse was greater in the lower calcium quartiles. So it was not related to high calcium levels. Next, please. And these are the most common drugs. It was SSRI and anxiolytics, benzodiazepines, and benzodiazepines for sleep. When it comes to lithium and neuroleptics, there were no significant difference and by calcium levels or yeah. So it was a lot greater than in the population as expected. And the prospective part, now we look forward after the operation. And it is a cohort study for analysis of the incidence ratio. Next, please. And in the prospective part, Poisson regression model was used for rate ratios. Next, please. And here we divided the cohorts into incident users, which means patients and controls that didn't previously get medication for neuropsychiatric symptoms, and prevalent users, that is patients and controls that previously used medication. And I think I will show you this to show the results, because the graphs are a bit tricky to look at, and I think this is interesting. This is from the supplemental table 2. Where you can see the progression or regression of the use of medicals. And these are the 3 most common and most important in this case. So what we found was that in incident users, new prescriptions, the prescription rate were higher among patients. And it kept on getting higher. It stayed higher in incident users, while in prevalent users it was lower than in the background population. And we could see a decrease in prescribing anxiolytics as well. Where at the first 6 months after operation, the rate ratio was 1.72, while already after 1 year, it was down to similar to the population with 1.05. And similar effects on sleeping medication, benzodiazepines, which had a rate ratio 1.8 for incident users. The first 6 months after the operation, and decreased within 3 years, but still higher than in the background population. So in summary, we could constitute that psychiatric diagnoses were more than twice as common in PHPT patients. And the most common drugs were SSRI and benzodiazepines for sleep and for anxiety. And the odds ratios were higher among younger patients and in patients with lower calcium levels. And after PTX, postoperatively, the drug initiation rate were still higher for the patients the first year after operation, and only SSRI and benzodiazepines for sleep remained higher 3 years after PTX. And in patients that were already on medication, the prescription rate remained equal to the controls, except SSRI, which was slightly lower than the controls. And there are, of course, some shortcomings in this study. And first of all, the patients were selected for PTX already when they were included. There is likely some surveillance bias in this. And there are also untreated PHBT patients hiding in the population cohort. And we did not have access to doses or size of packages. And neither we had the blood samples for the control cohort, and we did not have the PTH for the patients either. Yes, so we could conclude that psychiatric diagnosis and treatment for neuropsychiatric symptoms is more comprehensive in untreated PHBT patients. There was a decreasing trend found, but dispenses still remained higher than in the control cohort. And we consider that these results implies that neuropsychiatric comorbidity should be considered in this group of patients. They should be re-evaluated after parathyroidectomy. And as a summary, a holistic approach should be applied in the assessment of this patient group. Thank you very much.
Thank you very much, Anna, for a very clear and very nice presentation. Extremely interesting paper. And we start the discussion. So, yeah. Christina, we start with your questions first, please.
Yes. Now I can't hear you.
You're muted.
Yeah, okay, sorry. Well, thanks, Anna, for being with us today, analyzing the results of your study. In my opinion, one of the goals of the study is to demonstrate with objective registry-based data how surgical treatment of hyperpara could decrease the excess of prescription of benzodiazepines, because it means that surgery really improves the quality of life of patients. And this is clinically relevant. In the age of shared decision-making and humanization of healthcare, do you think that if we explain your results to the patients, they would ask for surgery more often?
Yes, maybe. I think it is extremely important to consider neuropsychiatric symptoms, just like other symptoms and complications like osteoporosis and so on. But it's also very important to increase the knowledge, and it's important to be humble in this and careful in what expectations you deliver to the patients. So yes, I think it is very important, but it's important to inform these patients that they might be that their symptoms might improve, but you should not put anything on them that they doesn't really complain about. That's my opinion about it.
Okay, thank you.
Yeah.
And one of the factors that you didn't consider is perimenopause period, since many of these neuropsychiatric symptoms could be partially due to this condition. In your study, 77% were female, 22% were in the 50s, and at this age, 12.2% reported neuropsychiatric symptoms. In 2009, Walker found it in this group a significant improvement in depression, anxiety, and self-reported quality of life 6 months after surgery. Could you give any special recommendation for this type of patient with the data from your study?
Yes, I think this is a group of patients that are overrepresented by females, and by females older than 50 years of age. And that's actually what is the dilemma, because all patients below 50 years of age should be offered operation if they like. So that's not really a problem. So it's absolutely of importance. And I think our previous study illustrates this very well, that we have good opportunities to help our patients also with these symptoms. But again, it is a dilemma to sort out who will improve and who will not. And I think it takes it should be it's a wish that we had good tests for this, and that's what we try to work out with this calcimimetic treatment. That's why I wanted to present this here today, because I thought it was relevant. But I think also it's in the end it comes to our art of our profession. I think we can't do this without it, and the relation to the patient and so on.
Okay, thank you. I have many questions, but I think I have to give the time to another panelist.
Yes, exactly. Thank you very much, Christine. Frederick, what are your views?
Hi, Anna.
Hi.
For this nice presentation and nice paper, very important to emphasize the psychiatric implication of primary hyperparathyroidism. Do you have a hypothesis on the mechanism of psychiatric symptoms with primary HPT? Because you clearly show that there is no correlation between the calcium level and the use of psychiatric drug. You mentioned that you could not evaluate, or you could not correlate with the PTH level because you do not have access to the PTH levels. But do you have any idea on what is creating those psychiatric symptoms needing psychiatric drugs in HPT, because it's not calcium level?
Yeah, no, I wish I had. I wish I had some more ideas about that. Most probably it has something to do with the calcium levels anyway, and the PTH levels. That's the characteristics of the disease. And it has been suggested different receptors, and we have at least 2 types of PTH receptors. And from what I know, the PTH receptor number 2 is the one that is mostly abundant in the central nervous system. But there are many biochemical and molecular biology factors that might affect. So it's still a lot to do.
A lot of questions, yes.
Without my reach, unfortunately.
And from a clinical point of view, do you currently include the use of psychiatric drugs as an indication for surgery? I mean, do you include them in your guidelines, like the T-score less than 2.5 and the calcium level above a certain level, hypercalciuria, etc.? So do you think it should be done?
No, we don't, and I'm not sure if we should actually, because as our results showed in this study and in other studies as well, we didn't find any correlation to the calcium levels, and we did not. We could also see that there was a inverse relation to age. And I believe I have no proof of that, but I believe that many older patients doesn't get these medications as often as younger patients that are more aware and more demanding sometimes. And I believe that is the same for operation, that many older patients are withheld operation more at a more extent than younger patients, and of course considering the guidelines, but even if you look at women above 50 years of age. So I don't think you should consider the medication explicit, but I think it's very important to ask about the symptoms and to catch them. I think that is important, but you shouldn't put anything on a patient that doesn't have the problem. So you need to use your artistic freedom in that, I think. But it would be very nice to have objective tools in this.
Okay, thank you.
Very good. If anyone from the audience has any questions, please use Q&A box to ask your question, okay? And now it's time for Oza. What crossed your mind after reading this paper?
Thank you, Marcin. Anna, thank you so much. It's very impressive to listen this from you tonight. And thank you for being on the platform once again. I have only one question due to the sake of time, and it's a little bit different than these clinical issues, because I see that you do a massive work regarding registry studies. So you have some experience. You used large databases, cancer registry, a population registry, a database for health insurance and drug registry. And this requires really very careful and concentrated work. And we already know that databases have potential flaws. And can you please share with us all the difficulties in carrying out such a study you underwent? And what would you advise us for those who are planning to work with the registries in such a way?
I think, first of all, I think Sweden is a kind of ideal country to study this, to perform these epidemiology studies, because we have these personal numbers that are included in everything. We hardly sell, at least not these drugs that we have studied. None of them are sold over the counter. They have to be prescribed by a doctor, and it's all registered, and also population data is registered by personal numbers. So that's really a gold mine for epidemiology studies. But of course there are errors, and also in the quality register there are errors, of course. So you have to interpret the data and the results with caution, I think. And then there are, of course, some administrative or bureaucratic obstacles. It takes time just to get the ethic approval, since it's personalized data at the beginning. Then it's we unidentified it, of course, when we did our calculations. But I think most of all, what I would recommend, that is to involve a professional statistician that you have a good collaboration with, because you need both the skills and the experience of doing epidemiological analysis in these large data sets. But you also need to collaborate with a statistician, so you get it anchored to the reality and to the clinical reality. So we had lots of discussions with our statistician, who is also a co-author, because he knows a lot about. He's very experienced when it comes to statistics, but he doesn't know the character of the disease. So we have to decide or consider, for example, for how long it's reasonable to expect that there should be any changes. We choose 3 years, which we thought was some kind of reasonable observation time. So yeah, I think that's the important take-home message. Don't be afraid of involving good people, knowing what they're doing, and collaborate tight.
Thank you very much.
Was there any other questions from you?
No, that's all, Martin.
Okay, we don't have any further questions from the audience. So thank you, Anna, very much for joining us. Congratulations for your excellent study. I'm grateful to all the invited discussants today, and I'm grateful to the research committee of the ESS headed by Oze Mackay for this initiative. And I hope that we meet again in 3 months with another very interesting paper. Thank you very much and have a good evening. Bye-bye.
Thank you very much. Thank you very much, every one of you in ESS. And thank you, audience, who listen. And I'm very sorry about the technical problems.
Don't worry. It always happens.
Thank you. Good evening.
Thank you. Good evening.
Good
Bye-bye.
evening. Bye-bye. Are we still online?
Yes, but we have 29 participants already.
Okay. Okay.
So
Nobody wants to go.
thank you very much. And now we search the literature for another interesting paper to discuss in 3 months' time.
Yes.
Okay. Thank you very much. Keep in touch and a good
And
night.
we hope you don't have to go back to the operating room.
I'm a little bit concerned that I have.
Okay.
So bye-bye.
Good luck. Bye-bye.
See you.
Bye-bye. Nice to see
Bye-bye.
you all. Bye.